gather the rest of our panel together for the discussion. And linking with Will's talk, the relationship of age to the polygenic risk score, was there anything that you observed there? Because he's talking about the elderly with the grey phenotype. Do you think the polygenic risk score is more important in the elderly presenting patient?
We don't have power at present to split the population. I don't think it will play out that way because too many factors come in later life. We see highest heritability in the individuals who are actually presenting at a normal age for HCM but don't have mutations. So that's why we got that very high heritability in our bioresource patients. But it is true that if you've got the polygenic tendency, then it's certainly not a young person disease. We don't see this in kids. We don't see it in 20-year-olds. And that's why we need a different approach to cascade screening. If we're sitting in sarcomere-negative HCM, the idea that you might follow up young kids in their teenagers every year is redundant, actually. And we're going to have to get our heads together and change the guidelines.
That's really important news to have in the future. So I hope that can translate very quickly. Nora, would you like to take on the next question?
Okay, are we going to go down in order of speaker, Elijah, or? Yes,
I think so. Why don't we go with the first question that we received?
Okay, all right then. So we did have a question for Juan during his talk, and that was whether he felt that the pediatric cardiomyopathy panel, the R135, should be, what were the circumstances you would use the R135 compared to doing a rapid exome and R14? Obviously, Juan was discussing some quite early onset phenotypes there. Has he got any thoughts about when he'd go for a cardiomyopathy panel or when he'd go for an exome?
Thanks for the question. So I think a lot depends on the phenotype of the patient. I think for most children with a sort of a clear hypertrophic cardiomyopathy phenotype, for example, actually sort of a standard cardiomyopathy panel is most likely to yield an answer. Have sort of other features of disease that sort of point towards a specific diagnosis. So, ventricular pre-excitation, for example, in somebody with left ventricular hypertrophy, then you may be able to sort of target your testing more towards that. I think perhaps in sort of children who present in the first year of life or two with a cardiomyopathy phenotype, then perhaps, and often without a family history, perhaps in that setting, sort of a larger panel or an exome might be beneficial. The rapid exome, we have tended to use that particularly in patients who are in our intensive care unit, for example, where a rapid diagnosis potentially can make a huge difference in terms of management, in terms of ongoing treatment and some of the treatment options that might become available, transplantation, things like that. But I think as a general rule, for most of the children that we see with cardiomyopathy, I think actually standard cardiomyopathy panels are probably likely to yield as good an answer as sort of broader, much larger panels.
Okay, that's interesting. We tend to find in Nottingham that for the children that we see with evidence of hypertrophic cardiomyopathy, we seem to get a lower pickup rate compared to some of our adult patients. Is that your experience at Great Ormond Street?
No, so I think our experience is the opposite, actually. So, so the yield of let's say sort of sarcomeric rare disease variants in our hypertrophic cardiomyopathy cohort is high. It's over 50. It's about 60%, 65% in our patients. Now that may be because we're not sort of putting forward for testing patients in whom there are features of other diagnoses, so metabolic disease, syndromic disease, for example. But no, our experience has been actually that the yield of genetic testing for sarcomeric disease and hypertrophic cardiomyopathy in children, even in young children, is higher than in adults.
I suppose I'm thinking of the patients where we've screened both parents and we haven't found anything. They're the ones that tend to stick in my mind.
Juan, can I ask, are there other phenotypes where you would reach for the exome before the panel?
So I think if you have so for example, if there are I think it is about the phenotype. So I think if there are features of say sort of concomitant left ventricular dilatation, or if there's evidence of conduction disease, for example, then I probably would go for a larger panel or an exome rather than a sort of a smaller sarcomeric panel in the context of hypertrophic cardiomyopathy. I would be guided by the phenotype.
I meant other diseases other than DCM, other than HCM. So for DCM or for your channelopathic patients that are presenting very prematurely.
So again, I think for the channelopathies, for the vast majority of cases, I think a sort of a standard inherited arrhythmia panel would pick up most of the cases, and the same for the other sort of heart muscle diseases too. I think where you have unusual features, so things that are different to what you expect to see in classical long QT presenting in the neonatal period, for example, then perhaps an exome might be helpful. But I think for the vast majority of patients that we see, at least, I think the sort of the standard panels, as long as the phenotyping has been good, is likely to give you as good a yield as anything else.
That's great, thank you. I think we had a question for Bethan from Eleanor Wicks. She asks if it would be helpful for us to formally define who is appropriate to have a virtual appointment versus those that require a diagnostic appointment. I think that was a feature. Are there any comments you wanted to make, Bethan, from that point of view?
Yeah, I mean, I think that extends beyond transition. From pediatrics to adults, but certainly it's something we're trying to work on at the moment. But obviously it involves a lot of different people in those discussions. So I know at the moment we're having lots of conversations with safeguarding, our learning disabilities nurses, etc., to see some of these concerns that the joint statement raised about access, confidentiality and whatnot, see if we can address some of these concerns. But not everyone's going to be appropriate for virtual consultations, and that's something we're just going to have to accept. But yeah, I think nationally there needs to be more guidance on this in addition to local.
Thank you. Nora?
We've had a question which I think is for Will Moody, who I think has just disappeared from my screen. I'm not sure if he's still there. Oh, he's just appearing again. Hi, Will, you with us? We've got a question that asks, it says, ECHO guidelines emphasize that left atrial diameter is a very poor marker of left atrial size, as AP diameter does not change much with LA enlargement, in view of being limited by a spinal column from behind. Why do we still use it for HOCM risk calculation?
Yeah, I think I just about caught that. If it related, can you nod if it related to left atrial assessment?
Yeah.
Great. So I think great question. I think the reason we're doing it is because that's what was in the ESC calculator. My feeling is that actually we should be doing bipolar atrial volume assessment. We do both in Birmingham, but I think until we see employing that in terms of risk stratification, we're going to continue to use a 2D or an M mode left atrial assessment. I mean, there are other ways of measuring the left atrial MRI as well, involving axial stacks and so on and so forth. My gut feeling is that I suspect that we're likely to see a change in the next 3 or 4 years, but until we see outcome data to support that move, we're going to be resigned to using a 2D dimension. I hope that's come across all right, because I can't see any of you moving or
So thank you for that, Will. And maybe just for the panel first to pipe up, from David Walker, how much would high risk in quotes HCM versus low risk in quotes HCM patient guide the level in first degree relatives?
It's our genetic counsellor here in Birmingham. I work closely with him. So I think great question. I think Professor Watkins has answered that probably, with his talk. Just echoing what he says, really. I mean, it was a fascinating talk from Prof. Watkins. I think that clearly there are two very separate disease processes going on. We're tasked at the moment with challenges in terms of resource and screening. I have to say we're putting a lot of resources into screening patients with very little yield at the moment. So we're having to think carefully, box clever in terms of adapting our service so that we can really identify those patients that will benefit from coming to the clinic. But I think, the jury is still out on the best to do that. But certainly, yes, when I see a referral, the first thing I want to know is the family history as much as anything else, because that will determine how quickly I think I need to see the patient.
Okay, so we're equating higher risk to more likely to be sarcomeric positive then.
Sorry, I'm really struggling with the connection.
Okay, well, I think Hugh nodded there, so I think that's there's a concurrence there. Nora.
Okay, we had another question in for Prof. Watkins. It says, do you think we're at our limit of genes for Mendelian HCM? And do you think it's likely we'll discover any new genes? And by that, I think they mean sort of traditional Mendelian genes rather than the low penetrance variants you were talking about.
I don't think we're likely to find high penetrance Mendelian genes because there are no families out there with multiply affected members over several generations that we've not sorted. There will be a middle ground between something like a myosin mutation and these common variants. And the last couple of relatively penetrant genes, I'm thinking filamin C and ALK-K3, are good examples because they have a penetrance of in the maybe 10% range. And that sort of gene, we will probably still find them because GWAS is very powerful for common variants. Linkage is very powerful for penetrant variants. The space in the middle, we're not so good at. So there's certainly room for variants that fit like an oligogenic model. And actually probably ALK-K3 might well fit that example. But I don't think we're missing very much at all in the penetrant Mendelian space. And it's knowing that we're not that allows you to say, okay, this negative result now clears away a lot of concern. Okay, yeah. And so from your point of view, looking at the data that you presented this morning, what do you think the way forward is for the gene negative families that we have in terms of the screening for relatives? What would you be recommending now? Yeah, and there was a very pertinent question about how you'd actually roll that testing out. I mean, the main thing I'd say at the moment is the inferences we can draw from the data are ready to put into action straight away. The fact that sarcomere, a good gene panel negative result, allows you to think differently about cascade screening and differently about comorbidity. So that's good to go. But of course, we'd like to actually type these common variants because I think they will help us predict in families with sarcomere variants and potentially outside as well. It's quite cheap to do a genotyping array, 20 or 30 quid in the research lab, but the NHS diagnostic labs are not set up to do them. So I don't know how easy it will be to get that to happen. It might happen if we start seeing the diagnostic labs, the hubs, doing this for PRS, polygenic risk scores for common disease, because you know they're useful for breast cancer and prostate cancer, coronary disease. So it might come for that reason. And it will come as a freebie once we have genomes, because you can extract the data from the genome, but you can't get it from an exome. So to drive it specifically for cardiomyopathy, I think is quite hard. And I imagine it will only happen if there's enough of a groundswell towards PRS in common disease that there are drivers to do it. And then once you've done an array, you get your readout, and it's fantastic. Each individual will be average for most things, but the odd person will be extreme for this or extreme for that. And there'll be the odd person, even at population level, who you could look at genetically and go, oh, you're at risk of hypertrophic cardiomyopathy. We need to watch your weight and your blood pressure and the comorbidity and try and protect them. So it will come, but I think it might stay in the research domain for a couple of years until we get it in the NHS.
I mean, Hugh, it's an interesting consideration of how we translate that to different populations, bearing in mind this is albeit a large research project, it's still a research data sets.
Yeah.
And so the context of how the polygenic risk score can be applied will very much vary depending on whether you're dealing with a large family, a very nuclear heritability in a family, or a sporadic case.
Yeah.
And I suppose that we're going to have to address different levels of probabilistic likelihoods of developing HCM or having HCM attached to the polygenic risk scores. And I think we're going to have that challenge. So yes. The polygenic risk scores as well.
I think so. I mean, the good news is it's computational. It doesn't need as much skilled laboratory interpretation. Trying to decide what a VUS is a hard human job, but tallying up a polygenic risk score is a computer job. So if we can get to the world where we are doing the genotyping, the readout is rather easy to generate. And then you get large data, exactly as you would need to know what it really means in the real world, rather than in our study cohorts.
And the interaction with rare variants is the next challenge.
Yeah, it doesn't. Yeah, we've got some data on that. It looks straightforwardly additive at the moment. And I can pick up a question I saw in the chat. Are these polygenic variants determining the likelihood of a yes/no diagnosis of HCM or the severity of the phenotype? And oddly, it's the yes/no diagnosis where we see power. They're not very powerful for predicting wall thickness. Don't know why. It could be because wall thickness is a lousy measurement, exactly as Will told us. And it could be when we get better at measuring it, we'll get a stronger correlation. But for now, they're just good at predicting the likelihood that a cardiologist will say you've got HCM.
Was it more effective with LV mass than with from the CMR studies?
Yeah, I don't have the answer to that. I hope so.
Yeah,
you'd like to think so.
Yeah, more granular.
Yeah, these are very new data, as you've seen.
That's very exciting data. Really impressed by it. Nora, I was hogging the time again, so maybe you want to.
Right now, I was looking at the next question was from Kay Metcalf, which we sort of partly discussed, but she's raised the issue of how you would go about approaching NHSE and the test directory. So I did make a note as Hugh was going through his talk about whether we're getting to a stage where we're going to be at odds with the test directory that's only just been agreed in terms of the criteria that we can test people under. And I don't know what Hugh thinks about that.
Yeah, I mean, I would be nervous. I understand you've got to not be wasteful in the lab. I'd be nervous if it became hard to get a gene panel test on a 55-year-old just because they've got hypertension and a 16, 17 millimeter septum. I think it's a really useful test. And Will's case is another example. That older patient, you could quite easily have said, oh, it's some sort of secondary composite thing, but it wasn't. And you get quite good value for money. So I don't want to open the floodgates and be testing willy-nilly, but I'm nervous that current entry criteria for testing might be a little bit too conservative.
Yes, and I think there's another comment from Karen Lowe in the chat just saying that the test directory criteria are stricter in terms of eligibility, and it makes it more difficult to test borderline cases.
The argument I think we should make is we should stand back and look at yield. And I would say if you look at the yield of a big array of arrhythmia genes for an idiopathic VF, it's not going to be very high. I think your yield of testing borderline HCM is going to be higher. So I think when we've got the data, we need to look at what the relative tests are for the relative yields are for the tests we're doing. I think the HCM yield, even when you're testing someone with a somewhat uncertain phenotype, is actually still quite useful.
Elijah.
Yes, I mean, we've got quite a lot of really good questions here. Mighty Tome has asked, is sarcomere positive HCM an age-parental disease then? I think, Hugh, did you want to interpret that?
Yes, I think all HCM is age penetrant. And I suspect the polygenic variants are explaining some of this divergence. I would love to believe that Juan's case of NYH7 that presented at age 8 had a very high polygenic load, and the 79-year-old who presented at age 79 had a low polygenic load. We would have to do the test and see, but that's the prediction. But for all HCM, whether you're on a myofilament mutation or not, there will be increasing penetrance with increasing age. It's just the point at which you'll convert to phenotype is very strongly driven by what the underlying genetic structure is.
That's really fantastic. I think we're at the end of our time. A brief interloper. So on behalf of Nora and the AICC, we'd like to thank Hugh, Will, Juan, and Bethan for their fantastic talks. Really a lot of interest, and we still had loads of questions there. So we look forward to the rest of the day and wish everybody a good lunch. And also, just to remind you that Randy Buskell will be doing the BHF-CRC Research Development Fund talk during the lunchtime session from 1 o'clock to 1:15. So